Okay, thanks guys for joining. This is the fourth webinar in a monthly series of webinars we're rolling out going through our template prescriptions. So I added 3 this month, and there's about 150 in there. So it'll go for a few years and then we'll probably repeat it. So thanks for taking the time to join us today. I might leave questions to the end if that's okay. So put it in the Q&A and then I'll jump to those at the end. Today we're going to go through toe walking, turf toe, Lisfranc injuries, and Pes Planus prescriptions for very flat feet. Similar to the other week, I'm just going to touch on our carbon fibre spring plates because there's recommendations for those spring plates in 3 of our templates today. So I'll spend 2 or 3 minutes going through how they work and why they work. So for those of you who don't have a diagnosis pack, sorry, phone's ringing, I would recommend looking at it. It's $99 and you get about $360 worth of carbon fibre. On Sunday, I coached a basketball rep team and we were in the grand final on Friday. I had one of my girls turn up and a letter saying she had Freiberg's disease. And the recommendation from the multidisciplinary clinic was to get a hair tie and tie the second and third toe together. And I thought, gee, what's that going to do? And no surprise, it wasn't doing anything, but I did have a diagnosis pack in my car, pulled out the extra small, put it in her shoe, and she had 90% relief straight away from that. So for those of you who don't know how they work, you should look at considering them for most mid and forefoot conditions. So they stiffen up the shoe and they prevent flexion at the MPJs. So it stiffens up and prevents that extension. They act as a bit of a rocket bottom sole within the shoe itself. And they're under 1 millimetre, so they're designed to go underneath the full length orthotic. They're not going to correct the biomechanical anomalies, but they will stiffen up the shoe, prevent that extension, act as a rocket bottom sole, and the toe spring, which is more evident in the tapered range, actually helps you to propel forward. So I won't go into too much depth because we've got a bit to get through today, but feel free to ask questions or send us an email if you want more information on that. So the first one we're going to go through is the toe walking prescription or template, sorry. So I'm just going to share my screen here. And so for those of you who are unfamiliar with the portal, you can just type any of these into the search bar. So toe walking, it brings up a couple of toe walking template scripts. So we'll touch on, we've actually got 3 in here. So we've got one with a carbon fibre spring plate, and then we've got full length extensions in carbon composite and poly-X. Now we don't have it in PA11 purely because PA11, if you do a full length orthotic, has a high risk of fracturing. Carbon composite orthotics, we have about a 5% fracture rate with the extensions in full length. We will remake those at our cost, but we'll change to poly-X or go for an orthotic with a carbon fibre spring plate if that person fractures it. So we'll jump into the first one, which is the carbon fibre spring plate. And as with all of our templates, I'm in our portal, so I'm just going to edit it. It gets me in there faster. As with most of our templates, I can't tell you the amount of riff or correction to use or the exact design to use. If you want to know more about all our different designs and when to use them, reach out and run a personalised webinar for you. Likewise, sometimes I can't tell you whether you should have minimal, medium, or a maximal fill. The main thing we're looking at here is providing an orthotic that corrects any of the other biomechanical anomalies. So again, hard to build that into the template. The material, I have no real preference in this first one. I do have preferences in the poly-X extensions, but for this one, we're actually finishing at the met head. So the 3D print PA11 performs differently to the PAX and the composite, and those can be found by drilling into shell material and having a look at the pros and cons and reading about them and looking at rebound rates and compression rates. But For the purpose, whichever material you decide for this is fine. You can even do an EVA orthotic. So the main thing with this is the carbon fibre spring plate, and it is required for this template. So you're basically designing an orthotic to correct their biomechanics, whether it's supination, pronation, what have you, and then you're looking at putting your carbon fibre spring plate. There is straight and tapered. Your tapered ones have more of a toe spring built into them. They have an elevated heel to accommodate most shoes that do have some elevated heel in them. If you have a flat shoe, then you can go for the straight ones, which are dead flat and can be used for left or right. But because of the taper and the toe spring, the other ones are left or right specific. So just going to go back to the other two, which are essentially the same thing, but out of composite or poly-X. Poly-X has a far greater elongation at break than the PA11 material does, which means it won't fracture, so you can bend it inside out and it won't fracture. Carbon composite, as I said, has about a 5% fracture rate. We will cover that cost with the remake, but we won't remake it in the same material. Sorry, edit template. So the main thing here being, again, you need to decide on rear foot and design. Correct any other biomechanical anomalies that you see fit. And then you're looking at using a composite material. We generally recommend the 3mm. The only disadvantage of doing this orthotic over the spring plate orthotic is that you've got this 3mm thickness in the toe box, whereas the carbon fibre spring plates you're looking at under 1 millimetre. So you do save 2mm in the toe box. But if you want to build the whole orthotic in with an extension to stop the patient from toe walking, then you need to really look at 3mm composite or 3mm or 4mm polypropylene or poly-X. And then just be mindful that you want to keep your full-length covers relatively low bulk. So you've got 3mm of composite. That's the reason I haven't added boron. We've gone for a 2mm medium density EVA. So you're looking at 5mm in the toe box. Important to get your wording right here, and we've sort of pre-filled it in for you. So we have been caught out a few times where people will say full-length composite orthotic. And what they mean is full-length composite, heel to toe, but that often comes across to us as being a full-length cover on a composite orthotic. So you may think full-length composite means full-length composite, but to us it'll mean a full-length orthotic. So the way we've worded it in here is composite shell needs to be full-length from heel to toe to prevent toe walking, and that essentially tells our team what you're trying to achieve. And the only difference between what we've just gone through there and the poly-X one, which is here, is the material change. So we've changed it from composite to poly-X. It does have a little bit more flex in it than the composite, so I have gone 3mm. You may need to up that to 4mm. If the patient's really getting onto their toes and you need more correction to push them back down. That's really the only difference. Same wording there, except poly-X shell needs to be full length from heel to toe to prevent toe walking. All right, so if you've got any questions there, jot them down and I'll come back to it at the end. Next one we're going to go on to is turf toe. So essentially, it's caused from hyperextension of the first MPJ, which results in damage and strain to the soft tissue and ligaments, often beneath it. So it's often got grade 1, 2, and 3. Grade 3 being a complete tear. So generally, we're looking at treating grade 1 and grade 2. So your partial tears or your stretch ligaments. So if we go into turf toe. So again, we've got two. So you're looking at using either a carbon fibre spring plate or like a Morton's extension. So we'll go through the Morton's extension one to begin with. And rear foot and design is somewhat difficult for us to determine for you, albeit we have gone for a mod route here. So your mod route is your most distally controlling orthotic. So if we just jump in here, you're upon ground reaction force, you're actually dorsiflexing the first ray. And so we generally recommend that only in situations where we're dealing with injuries to the hallux, turf toe, hallux rigidus, hallux limitus, sesamoiditis, where elevating the first ray may be beneficial. In most other cases, we're looking to engage windlass, first ray function. We're trying to drop the first ray, but there may be some benefit here to doing the mod route, which elevates the first ray. And so here we're looking at your Morton's extension. Should be left and right. I always do these templates bilaterally, and it's up to you to remove, left or right, depending on what you've got. And we've opted to go for the shell. So if we look at Morton's extensions here, these are the three types that we offer. So you've got your normal one, which finishes at the end of the sulcus, normal and wide, which protects first and second. So you've got like a plantar plate tear, or you've got hallux abductor valgus or something, and you just need a wider platform. So with these two, you're looking at long and wide. So and generally because turf toe is generally experienced with people that are playing rugby, football, cricket, things like that. If they want to remain active, what you'll see a lot of people doing is still propelling off their big toe, and all you get is that sort of dorsiflexion at the distal IP. And so what we generally recommend is going for a full-length Morton's extension. And typically we'll go wide. Keep in mind, you can always cut it back pretty easily to this length if you don't need it, and you can always cut it off altogether once the injury is healed. Important to note here that we've gone for poly-X. So if you go to 3D print your PA11, there's a fair chance a long extension like that will fracture. It's just not designed to be bent to that extent. Same with composites. So some people like to use your composites because it's a little bit thinner than your poly-X and your PA11. However, you've got probably a 5 to 8% fracture rate on Morton's extensions. So again, we've decided if you want it, we'll do it and we'll cover the remake of it, but we won't remake it in the same material if you fracture it. So essentially, and then do you want to do a Morton's extension with a carbon fiber spring plate? Again, you may want to go for a thinner material, so like a 2 mil for toe box reasons or space in the shoe. And you can put a carbon fiber spring plate underneath it, and you can also do that spring plate in a Morton's extension style. So if I just jump onto our educational website into carbon fiber spring plates, and go down to custom. So you can do a Morton's extension like that. So you can do a thin sort of 1 mil carbon fiber spring plate that sits underneath your Morton's extension. So there's no reason why you can't add that as well. Okay, so that's sort of, our goal is to prevent hyperextension, which your Morton's extension is going to do. And we're often trying to protect the interphalangeal joint as well, which is why we go for that long Morton's extension. And it's also why the carbon fiber spring plates that we modify to a Morton's extension are generally on the longer side. So that's with your Morton's extension. This is essentially without your Morton's extension. So you're only going with the custom Morton's extension on the carbon fibre spring plate. Generally, you do that for spacing the shoe. So again, we've got that mod root design to help elevate that first ray, and everything else is the same. Opted for poly-X, and then we're getting down to a custom Morton's extension. Carbon fibre spring plates required. So we've even got our Orthotic hyperlink hooks to that shape there, so you can just throw that in, brings you that page, and you can see what they look like. That's an out-toe gate plate. We could do in-toe gate plates. That's a plantar plate tear modification on spring plates, and there's other things that we do, but that's just some examples of what you can do with those carbon fibre spring plates. Just remember, if you don't want something like this, just remove it from the notes. Just leave it. If you leave it there, chances are you're going to get that spring plate, whether you want it or not. All right, we've got about 10 minutes to go through Lisfranc and Pes Planus. So jump onto Lisfranc. All right, so I'm just going to bring up a image. Just give me a sec. So we're starting to build out a bit of a visual of the different conditions on our website. We haven't quite got there yet, but if we look at just this image here, that's your Lisfranc. You've got your dorsal ligament, your plantar ligament, and your interosseous ligament between first gematiform and the second metatarsal. So essentially, we've had damage to that, whether it be, twisting of the foot, whether it be, something dropped on it, some sort of form has occurred to that. And so essentially we're trying to stabilize it as much as we can. And it's not a dissimilar script to some of the midfoot osteoarthritis stuff that we do, although there are a couple of changes. So I may bring that image back in a moment if need be. But essentially, if I go to what we're trying to achieve, we're trying to prevent inversion of the foot. We're trying to prevent eversion of the foot. We're trying to stabilize the midfoot. And so a couple of different ways that we do that. One is by inverting the rear foot and everting the forefoot. We're kind of locking those midtarsals together, and then we're preventing inversion and eversion. So we're preventing too much movement in either direction. We are going to a mod root part first ray fill because we're starting to introduce a forefoot valgus to lock up that midfoot. If we introduce a forefoot valgus with a mod root, we're kind of counteracting one another. We're trying to, invert both the forefoot and evert the forefoot. And so you want to start to take contact away from the foot on the medial side. And saying all this, you may need a rear foot device, which is different. So again, I can't tell you exactly which design and rear foot and forefoot to go for because there's other factors at play. Go for a minimal arch height because, again, we're trying to prevent too much eversion and inversion, so supination, pronation, whichever way you want to think about it. So that's as far as that base design goes. And then we've also introduced calcaneal inclination angle, just a small one. So your calcaneal inclination angle, if I jump into it, is a small incline anterior to the calcaneus. So it's like a very small cuboid notch, I guess, that runs all the way through. And the idea behind that is upon heel strike, supporting anterior to the calcaneus actually decelerates pronation. So prevents any or the small amount of plantar flexion of the calcaneus that can occur during pronation. So if we decelerate that pronation, if we support the lateral column and prevent any inversion, medial column eversion, then we're kind of locking everything up, stabilizing that midfoot. And then, oh, hang on, not on the script. So two interesting things that you may want to consider. One is, the other thing we want to do is to prevent that late stage pronation is we want to resupinate early. And so by allowing the first rate to drop, along with that forefoot valgus, all the research shows that you resupinate earlier and you prevent that late stage pronation. Now, typically, a first MPJ cutout will work better with a reverse Morton's extension. You're allowing that first rate to sit lower, which then allows earlier resupination, windlass, etc. I'll put a modification down here, actually a couple of modifications. So forefoot valgus to sulcus, so 4 mil EVA. So what that does is, again, limits any inversion of the foot late in the gait cycle. But in the notes, I've suggested a possible modification, which is consider tapering forefoot valgus from 4 mil laterally to 2 mil medially, combining a forefoot valgus with a reverse Morton's extension into one. And so we might I'll show you what that looks like. So we've got this orthotic conditions section on the education website, and you can then drill down into, there's our 28 most common additions where you can drill down into those and have a look and read about them. Most people are aware of those, but next door to that, you've got additions in notes, which is just things that we're slowly adding. And so one of them is combining forefoot valgus with a reverse Morton's. So we're looking from an anterior view here. So taking it from 4 mil laterally down to 2 mil medially, you're getting that valgus force, pushing the forces back medially, but you're also combining it with a reverse Morton's extension that allows that first rate of drop, windlass to kick in, earlier resupination. So again, it's in the notes as a consideration. It may not be applicable to that patient, but again, it says delete the notes that you don't want. So again, we're dealing with a mid or a forefoot issue. So consider a carbon fiber spring plate. So that's going to do as much as you possibly can within an orthotic or a Lisfranc injury. If we're doing a calcaneal inclination, forefoot valgus, rear foot varus, carbon fiber spring plate, and a reverse Morton's underneath that forefoot varus, you're basically throwing everything at it now. You may not need all that, but we've put it in there just for your consideration. Again, delete what you're not going to use. Last one, we've got 5 minutes, and then I'll do Q&A. I'll probably finish a little bit earlier. Just jump back into Pes Planus. So Pes Planus, we have two. We've got severe and just the normal Pes Planus. They're both loosely based around your medially deviated subtalar joint axis, which I'll touch on quickly. So here we've got a 20-degree inverted orthotic. So this is one of the scripts where you do need to use one of the rear foot devices if you're correcting Pes Planus foot type. Reason being is that, look at this image here. So it's loosely based on this medially deviated subtalar joint axis theory. So that axis, there's 3 axes here, but the axis can really be anywhere. They talk about, normal being posterior lateral calc through medial second met head, but it can be anywhere from, going through the fourth through to, posterior navicular. So if you look at this as a Pes Planus type axis, if you like, and I'll move on to the severe one in a moment. Theory being that anything lateral to that axis upon ground reaction force is a pronatory force. So you put that foot on the ground, the vast majority of it is a pronatory force, and the foot's going to pronate. And so it sort of looks like this. So you've got to get all your control into that medial to that axis. So first you need to find the axis. And you're looking at your inverted orthotic, which peaks at sus and taculum tale. And then you're looking at a starting point of 20 degrees. And I say a starting point because we have, wrong section, we're going to designs, rear foot. We look at inverted. So we look at a ratio of 1 to 5 as a starting point. So if the neutral calcaneal stance position is 4 degrees and then you're looking at multiple of 5, 20 degrees is a good starting point. So there will be other things: supination resistance, Jack's test, activity, first rate function, a bunch of other things. But we still get a lot of people doing a 3, 4, 5 degree inverted device. And when I talk to them about it, they say, oh, I'm a conservative prescriber. I don't like to go too high on the rear foot. All you're doing is asking a lot of the medial posterior arch if you don't go high enough. So in a closed chain environment, when you invert the calcaneus, you lift the arch, you pick up the articulating joints, the talus head, abducts and dorsiflexors, picks up intertarsals, etc. But if you don't get that initial calcaneal inversion or varus correction, then you're just going to have fine soft tissue just resting on the medial side of the orthotic. So I almost think a 3 or 4 degree inverted orthotic is more aggressive than a 15 or 20 degree one. You need to get all your control medial to that axis. So you've got to get up around sort of 20 for it to do anything. And so I guess that leads me on to the severe pes planus, which changes the design slightly into our true inverted orthotic. So this is where you've got a really medially deviated subtalar joint axis, your navicular is sitting on the ground, and what we've done is move the high point more posterior, so it's almost medial calc. So we introduced this about 5 or 6 years ago because some people were finding that they may measure this axis non-weight bearing, so let's say posterior lateral calc through the navicular, but then when the patient stands up, everything shifts medially, and that high point was too far forward. So we've shifted it right back, and because it's gone back, we're dealing with a much smaller area of the medial calc to do all that fighting against such a large pronation moment. You're really looking at probably increasing that rear foot to something like 30 degrees. Now, I might just, because it's almost 1 o'clock, I'll just touch on the designs a little bit. The reason these peak early and drop away really quickly is because, and I might use the inverted, it's probably a better image to show it to you. So, well, actually, I'm going to jump back quickly into midfoot. So the more parabolic an orthotic is, the mod roots, perfect example, the stronger the orthotic is. That is a harder orthotic to flex. If you go 2.5 mil in that orthotic, it's going to be stronger than the part first rate fill because, or at least anterior from the high point, that will flex easier, and then your full first rate fill will flex even more. And that's what you're trying to achieve with those orthotics. So if we go into the rear foot, the reason they peak early and drop away is so that there isn't too much control in this area of the foot. So lateral and anterior to the axis. If you're too prominent there, then two things are likely to happen. One, you're entering the pronatory moment. So if you're too full here, chances are you're actually going to pronate that foot rather than prevent pronation. And generally, patients will find it very uncomfortable. They'll get blisters, rubbing, things like that. So it drops away for two reasons. One, it takes contact away from the foot. But if there's contact, it'll also bottom out pretty quickly. So, right, here we go, half an hour, 4 conditions. All right, I'll stop sharing, and then if there's any questions, I'll answer those. So I'm just jumping into the Q&A. No questions? Easy. Well, feel free to post some if you want me to answer anything. Alternatively, you can make contact with us directly, hello@orthotech.com.au, or you can reach out directly to me. But if it's a question for me, it'll get passed on anyway.